Orton from Colorado State University, a true pioneer in veterinary cardiac surgery who has shaped the field for decades. Thank you for presenting today.
Thank you for inviting me.
Thank you.
I appreciate it. I think this is a nice opportunity in the same forum to compare two very promising approaches to this disease. Okay, so this is. Are we good? All right. Transcatheter edge-to-edge mitral repair. On this first talk, I'm going to talk about the procedure, a little bit about what it is, focus maybe a little bit on the role of the surgeon, because this is a procedure that combines the skill sets of the cardiologist and the surgeon. And then in the second talk, I'll talk about our data on outcomes. So these are my disclosures. The first one is relevant to this talk. Okay, it's the wrong talk. Did they get loaded backwards? Yeah, that's the one. Okay, sorry about that. Okay, what is edge-to-edge repair? The concept of edge-to-edge repair was first proposed by an Italian surgeon in the 90s, Alfieri. At the time, there were not good techniques for dealing with prolapse of the anterior leaflet. In humans, the posterior leaflet is usually the problem. In dogs, it's the anterior leaflet. And this was, even though this was never widely adopted, Alfieri reported very good outcomes with open heart edge-to-edge repair. The idea was to suture the leaflets together at the point of maximum regurgitation. But this led to the development of transcatheter edge-to-edge repair, primarily with two devices, the MitraClip device, which you've probably heard of, and also the Pascal device. And this has undergone significant development in the last 20 years. It's a very interesting story to look at their progression and their learning curve and how they started out. But anyway, a company in China decided to develop a device for dogs. The device is different in that it is not a fully percutaneous procedure. However, the concepts are very similar. The idea is to bring the leaflets together using a device at the point of maximum regurgitation. So, if we think about this procedure, this is a classic hybrid procedure which combines a transapical approach through a minimal incision thoracotomy with transesophageal echo and fluoroscopic guidance. So it's a nice marriage between the surgeon and the cardiologist. This is what the device looks like. The device now comes in 5 different sizes. Originally, we didn't have the 2 larger sizes, and what we were finding was a lot of dogs, particularly Cavaliers, their heart was too big for the devices that we've had. Anyway, it's you can see basically that this device is a clamping device intended to capture both leaflets simultaneously. It's locked. It's delivered through a 14 French introducer. For the two larger sizes, it's 16 French. So the team, how do you start a team? How do you think about this? One of the things that I really enjoy about this procedure is the team nature of it. So I would say the key team members consist of an anesthesiologist, a sonographer, a cardiologist, one or two, and a surgeon. Now, we'll look at the technique here momentarily, but currently it's a two-operator technique, two sets of hands to actually capture the valves and deploy the clamp. Now that can be two interventional cardiologists, or that can be a cardiologist and the surgeon can play the role of the second operator. Each one of these individuals has a significant learning curve. I could not really overemphasize the importance of the sonographer. The operators cannot do this procedure unless they can see the structures in the heart, how the leaflets are moving, etc. So there's learning curves. There's people in this audience who do this sonography, and they can tell you the learning curve is a little bit steep. Okay, a little bit about the anatomy and what we're doing. Of course, the anterior leaflet of the mitral valve is in fibrous continuity with the aortic valve. The base of the anterior leaflet is fairly short. It's only about 20% of the circumference of the annulus. So the anterior leaflet is basically anchored here. So really, when we think about edge-to-edge repair, you may be familiar with this terminology where both the posterior leaflet and the anterior leaflet are segmented into these segments called A1, A2, A3. We use this terminology a lot to talk about where the clamp needs to go, etc. One of the key anatomic guidelines is that we need to identify the true commissure. People might think the commissures are here or somewhere in this area. They're really quite short, and this really identifies where we need to put that clamp. That clamp is typically going to go right down the middle. Right now, this technique is most appropriate for a leak that's originating at A2 and P2. We have ventured a little bit outside of that zone, but as far as going into the commissures, we're not ready to do that yet. We'll talk about, I'm sure we're going to discuss a lot about surgery versus TEER, but one of the things about TEER a little bit is that it is a little bit limited by the anatomy. Okay, what does the imaging look like? Typically, these dogs are actually in lateral recumbency with the right side down. The surgeon stands on the ventral aspect of the patient. So, being a surgeon, you're very visual, you're very spatial. If I know the dog's head is to my left, I know that the aorta is to my left. When I set up the imaging, I want the imaging to reflect that. I want the imaging for the aorta to be on my left for all of the different modalities. Now, this procedure is actually done under transesophageal echo and fluoroscopic guidance. It can be done with echo alone, but we believe that these are quite complementary. The echo shows you the structures, the fluoroscopy shows you the device, and they're very complementary. The transesophageal echo, there's two imaging modalities. the so-called biplane, which you can see here, which shows you a commercial view, side to side, if you will, and an inflow-outflow view, or anterior posterior. So you can see the clamp is here. We're going to grasp these leaflets using this view right here. This is going to help us stay medial and lateral. And then we also use the 3D en-face view, which helps us with rotation to make sure that we're properly oriented. When we set this up, the way we set this imaging up is we, again, to help the surgeon think about this in spatial. This is, this is a lot like laparoscopy, or thoracoscopy, where you're using your image to guide the procedure rather than actually looking at it. So when we set up the imaging, we place the aorta on all of these views, the fluoroscopic view, the inflow-outflow, and en-face, with the aorta to the left. So that when we're manipulating the device, and really the learning curve for the operator is how to manipulate the device outside of the dog to get it to do what you need it to do on the imaging. So you can see we're moving the device medial, lateral, cranial and caudal, anterior, posterior rotation. So we spent quite a bit of time, usually something close to 40 minutes or longer, doing a pre-procedural TEE study, studying the valve, understanding the mechanism of mitral regurgitation, and formulating a plan. Again, in dogs, the dominant defect is usually the anterior leaflet. The posterior leaflet might be involved. That makes it more complex. So we're going to review the mechanism. We're going to identify the location of the commissures. We're going to agree, okay, this is where the clamp needs to go. We're going to identify any clefts in the posterior leaflet. That does not limit the procedure. We just need to know where they are. One of the things we've learned is clamp sizing. This is a critical aspect of this procedure. We've learned not to undersize the clamp. We want to get as much leaflet as we can. We base clamp size by measuring the AP dimension in mid-systole. And then we measure the length of the leaflets. The reason we do that is we want to know how much leaflet we've captured. So after we capture the leaflets, we'll measure what's left over, and we'll make a decision before we release the clamp, whether or not we've grasped enough clamps. So, transapical approach, basically it's almost always in the 7th intercostal space. It's very close to the sternum. We do need to be aware of the internal thoracic artery. With experience, it's fairly straightforward to avoid that. The transapical approach is going to be quite familiar to a surgeon who's used to doing thoracotomies. The interesting thing about it is quite small. It's usually about 2 centimeters. You can see the size of my fingers there relative to the incision. Okay, I don't have the smallest fingers in the room, but it's not a very big incision. So it's an intercostal close to the sternum. We open the pericardium, we lift up the apex to get access to it. Now probably one of the most important steps in this procedure is to identify the cardiotomy site. We want a cardiotomy site that's perpendicular to the mitral annulus on both views as much as possible, especially the cranial and caudal. We don't want to come in tilted relative to the valve, or it will be difficult to capture the leaflets. So the way that we do that, you can see here, is once we've done the approach, we're going to press on the apex, and the sonographer is going to help guide us to that very optimal spot for placing the sutures. Once we do that, we place 2 pledged reinforced mattress sutures. That will be straightforward to most surgeons. we place them at right angles to each other and bring them through normal tourniquets. So this is what the procedure looks like. So the first thing we're going to do is we're going to get access to the left ventricle by introducing an 035 wire into the LV. We're then going to use that wire to put in the introducer. We're not going to cross the mitral valve. Once the introducer's in, we're going to use this mitral device, which has a soft nitinol tip, to cross the mitral annulus and across the valve. That's going to decrease the risk of them trapping a cord. So once that mitral device is crossed, then we will follow that with the introducer into the left atrium, and then everything is removed. So now we have our introducer for introducing the device. So the key step, of course, now is to introduce this clamp into the left atrium. So we typically, at least for the first clamp, we open the entire device in the left atrium. So what we're seeing here is the operator's first chance to sort of get oriented, make sure the rotation is correct. So you can see up here on our en-face view that we've got the rotation straight across anterior posterior. And we're going to open the bottom clamp, and again trying to stay in the left atrium here to begin with. Let the air clear. So you can see the first operator is responsible for positioning the device. The second operator is, there's actually 3 operators here, but the second operator, which is Dr. Scanson in this case, is opening and closing the device, and he will actually do the capture. So we're dropping below the mitral valve now with the bottom arms of the clamp. Again, continuing to try to hold our orientation so we don't entrap Corey. Come up towards the mitral valve. Typically, we are in the heart for between as little as 5 minutes, 5 to 10 minutes is really the procedure inside the heart. Come up to the valve, and then the second operator is going to do the capture, and currently we're emphasizing capturing during diastole. So we see the leaflets coming down, we try to time it down, 3, 2, 1, clamp. And that really the key to this procedure and avoided complications with this procedure is capturing the leaflets well and capturing them for the first time. I'll show you this case shortly afterwards. This was a cavalier. You can see the hemodynamics here. Typically we see quite a dramatic response in either the heart rate or the blood pressure, which is one of the nice things about this procedure. You get immediate feedback on how you've done it. Unlocking the device here. Now, we spend a lot of time making a decision about whether this clamp has captured the leaflet appropriately. We measure the residual leaflets, we measure the gradient into the valve, across the valve, although mitral stenosis is virtually never a problem. And we really make sure that the entire group agrees that we're ready to deploy this clamp. So first operator, this is usually the longest 5 minutes of your life, just trying to freeze this thing and hold it in place while everybody's deciding whether you can release it. This is where fluoro is very useful, because fluoro really, since echo is going live and then they're making measurements, fluoro is live here, so we can really focus on this. Okay, second operator now is doing the clamp release. And you can see, I don't know if you've been looking at the pressures, but the diastolic pressure is approximately double. Now, actually, I'll show you this case in a little bit. That's what the clamp looks like. We want a clamp that's moving up and down. We actually did 2 clamps on this cavity, which I'll show you in a bit. Okay, as we've become more experienced with this, we are now, if the size of the dog allows, we're getting better reduction in mitral regurgitation in some cases by going with double clamps. I'll show you the data on that in the next talk. Okay, a little bit about the post-op. The antithrombotic management, we typically give 50 units of IV heparin during the procedure. We do not reverse with protamine. We give enoxaparin at 4 and 12 hours post-procedure, and then we start clopidogrel the morning after the procedure. We continue clopidogrel for 3 months. Thoracostomy tube can usually come out within a few hours. There's basically no bleeding in most of these dogs. I think one dog had moderate bleeding, and that was due to the internal thoracic artery. Most dogs will have an accelerated idioventricular rhythm. We do not treat this. It tends to be self-limiting after 24, 48 hours. 4 cases of experienced atrial fibrillation that has spontaneously resolved prior to discharge. We continue pimobendan in all dogs. That's been shown to prolong survival in mitral valves, so we're not prepared to decrease or discontinue the pimobendan. We'll let the cardiologist make that decision. We will adjust the diuretics as we feel necessary. This is what I like about this technique. If we compare surgery with TEER, each of these procedures definitely has advantages, but the principal advantage, in my opinion, of TEER is the level of invasiveness. We discharge all dogs in 1 or 2 days after the procedure. These videos were taken the following morning in the first number of cases. This is absolutely typical, except for this little guy here. That was the same afternoon as the procedure, and he's already walking outside. I'll finish by showing you a case. Maybe we'll have time for a couple questions. This is an 8-year-old female cavalier, and this one is in stage D. Cavaliers are the poster child for not going into failure and having extremely advanced B2, so we have no problem doing cavaliers in stage B2 if they have severe mitral regurg. You can see the numbers here for the cardiologists in the group. This dog is significantly remodeled, but perhaps the easiest one to understand is regurgitant fraction. Regurgitant fraction says what is the percent of blood going backwards through the mitral valve versus going forward. And the regurgitant fraction is 72%. In a human patient, anything over 50 is considered to be severe. This is very typical of the dogs that we do procedures on. In fact, the average is over 60%. Regurgitant volume 2.9 mils per kilo. This dog has severe anterior leaflet prolapse, very high E weight. So this is what his TE looks like before. He has very shallow coactation. And this is associated with, as has been discussed, the amount of annular dilation. He's got a wide regurgitant jet on his commissural view. The vena contracta area is 0.9. In the human, adult human, anything over 0.4 is considered to be severe. So these dogs tolerate an amazing amount of regurgitation, more than we should really allow. After the first clamp, this is the case I just showed you on the video. Okay result, but there's still leak around the clamp, so we decided to do a second clamp. Already he has a reversal of his inflows. His E wave is less than his A wave. For a cardiologist, that means something. And his vena contracta area is now 0.8. That's the following morning. This is very typical. 2 days after surgery, we can't measure the regurgitant fraction. It's essentially 0. So this is a very good result. We don't always achieve this level of mitral regurgitation reduction. I'll show you that data in the next talk. So with that, I'll say thank you very much, and maybe we have time for one question.